Very pleased to welcome Sven from Dublin, who will talk about bimodal peripheral nerve stimulation as an avenue to treat neurological disorders. Sven.
Good morning, everyone. First of all, Gert, thank you for inviting me. I'm a neuroscientist. I'm not an engineer, so I was a little bit confused when I got the invitation. I sent him an email saying, "Are you sure you want to invite me?" But he really wanted to talk to me about peripheral nerve stimulation, so that's what I'm going to do today. So if we look at the brain, we have these brain nuclei that are really central in a lot of diseases. We have the locus ceruleus norepinephrine pathway, we have the ventral tegmental dopaminergic pathway, the raphe nucleus serotonergic pathway, and the nucleus basalis cholinergic pathway that play a key role in different neurologic and neuropsychiatric diseases. And we know if something goes wrong down these pathways, we can develop specific neurological and neuropsychiatric disorders. We have different approaches to basically directly try to modify the brain using the brain stimulation or surface electrodes or transcranial magnetic stimulation to directly change activation in the brain and also indirectly sometimes activate one of these pathways. But there's more and more interest also for peripheral nerve stimulation, and one in specific is the vagus nerve stimulation. It's already used, quite common for people that have epilepsy or depression that do not respond to any other treatment, and it seems to be quite successful. But what is interesting is that peripheral nerve stimulation has a lot of potential, but it's not only the vagus nerve. Today I want to talk about vagus nerve stimulation, but also trigeminal nerve stimulation and occipital nerve stimulation, and how they could help potentially different neurological and neuropsychiatric diseases. And I will first talk about the vagus nerve. So what is interesting about the vagus nerve is that when you stimulate the vagus nerve, that it actually activates a nuclei in the brainstem, the nucleus tractus solitarius, that has connections with all these other brain nuclei, that induce the release of these neuromodulators. We also know that we can actually activate the vagus nerve in a non-invasive way. You have an auricular branch in the ear, in the concha, that can activate the vagus nerve. The problem is that it's not quite clear if we're only activating the vagus nerve, because as you can see, there's a lot of nerves close to it. You have the trigeminal nerve that's next to it. You have the occipital nerve that is also very close to it. You have a branch of the facial nerve that's also very close to it. Anyhow, what we know is that if you activate the concha within your ear, you activate definitely also the vagus nerve, and it induces a lot of brain changes. But it's one thing to basically activate all these brain areas and induce these changes and potentially induce neuroplasticity. But of course, it's spread all over the brain. But a couple of years ago, our group was able to show that if you pair vagus nerve stimulation together with a sensory task, and in this case, it was an auditory stimuli that we presented, that you can actually target or drive plasticity in a very specific way. And we set up an experiment where we had rats that we basically exposed to noise exposure, and they developed tinnitus. And it's quite easy to test them by using a gap detection method to see if they developed tinnitus. Those animals were assigned to one of those three groups. One group basically just perceived tone therapy, meaning they just were hearing different types of frequencies with the exception of the tinnitus frequency. Another group of animals received just vagus nerve stimulation. And then a third group got basically the paired situation where we basically pair vagus nerve stimulation together with tone therapy. And what we saw was actually in those animals that we could normalize neural activity in comparison to the other two groups, and that those animals, after the treatment, had no tinnitus anymore in comparison to the two other groups. So it seems that pairing vagus nerve stimulation together with sensory input, in this case auditory stimuli, that we can actually really target and induce plasticity in a very specific way. In addition to that, we were also able to show that actually we could normalize the map. We know that the auditory cortex is organized in a tonotopic way, and that you can basically see from lower frequencies up to higher frequencies that it's organized in a very specific way, and that in tinnitus, in animals that have tinnitus, that you get an overrepresentation of certain frequencies on that map. But after paired stimulation, that map normalized again and is closely to actually before noise exposure. So this suggests that it actually has a lot of potential. So we went and developed a device together with a microtransponder that allows us to stimulate the vagus nerve, but at the same time communicate with the computer so that we could pair auditory stimuli generated by the computer and peripheral nerve stimulation. And this was just an efficacy study where we basically implanted, and it was a multi-center trial. There were 4 centers involved here in the US that were involved in that trial. And about half of the people that were enrolled in the study were assigned to the paired treatment, and half of them were the control group and received the unpaired treatment. The treatment was for 12 weeks, but at 6 weeks we had an interim analysis. And what was also different was that for the control group, after 6 weeks, they would cross over and receive the pair treatment. Our primary outcome measure was the tinnitus handicap inventory, which is a typical measure for tinnitus severity, and we know that a drop of 7 points on the THI is actually clinically meaningful for patients. What was the exact difference between the 2 arms? So for arm 1, we paired auditory stimuli together with a burst of stimulation on the vagus nerve, and we presented different types of tones randomly, with the exception of the tinnitus tone and a notch of half an octave above or below the tinnitus tone. Every 30 seconds, we stimulated the vagus nerve, which was a burst of 15 spikes together with a tone. And patients had to do that for 2.5 hours a day for 12 weeks in a row. The control group basically got also 2.5 hours of training, but the difference was that they got 15 minutes of just auditory stimuli, followed by 2 hours of vagus nerve stimulation, and then again 15 minutes of auditory stimuli. To our surprise, if we compared arm 1, that basically was the paired treatment, with the unpaired treatment in arm 2, both groups actually generated an effect that was clinically meaningful. You could see that there was a drop that was higher than, or that was more than 7 points than what was that is needed for the medical clinical outcome. So, but both groups dropped more or less at the same rate. If you look at 12 weeks, remember after week 6, the people in the unpaired group now also received paired treatment. No effect was generated anymore. We see a fast-acting effect, but it doesn't really matter if it's paired or unpaired. In both groups, we got an effect. What was a little bit more encouraging was that if we look at the electrophys, we saw that actually there was a change in the auditory cortex and that we saw a reduced power or a decreased power activity in the auditory cortex after treatment for the gamma frequency band. And we know that the gamma power, it correlates with how loud people perceive their tinnitus. At the same time, we saw that there was increased alpha activity within that auditory cortex, which is normally what you would expect at rest in healthy controls. In addition to that, we saw that there was reduced laggard phase coherence between the auditory cortex and frontal areas that are related and have been shown to be related to tinnitus-related distress. So it could be that the effect that VNS was generating was just more related to the mood component than the tinnitus itself. One explanation for that is maybe that VNS is very good for modifying the mood component if we look at positive symptoms, but that it could actually help for negative symptoms if you pair it with another treatment. So in another efficacy trial, we enrolled 21 patients that had ischemic stroke, that had upper limb problems. And the idea was, let's compare people that just get regular PT with people that get PT paired with vagus nerve stimulation. So every time that they were successful in executing a task, we would at the same time stimulate their vagus nerve. What was interesting was that if we compare those two groups, that actually the people that got vagus nerve stimulation paired with PT were more successful, although it was close to significant but not significant, in comparison to people that just got PT. This was only a small trial, and now we're doing a phase 3 trial where we enroll 130 patients, and so far it seems to be quite interesting, the effects that we are generating. At the same line of interest, again for negative symptoms, if you look at spinal cord injury that we induced in animals, what is interesting, if we pair vagus nerve stimulation with basically pulling force, and the 20% most successful trials in pulling force and paired with vagus nerve, we see that recovery in those animals that had spinal cord injury is going a lot faster than basically just rehab, or if you pair vagus nerve stimulation with the bottom 20% of pulling force. So it seemed that pairing is doing something, but it's not quite clear when it's doing something and when it's not helping at all. But at the same time, what we're trying to do now, because, well, it's just a pain to implant all these patients with a big IPG and an electrode, we try to basically make it smaller nowadays, that you just have the electrode and all the wiring is gone, and basically the battery is not implanted anymore, and you can basically connect it to an iPhone or a smartphone and generate the pulses from your smartphone. So that's something that we're working on right now. Anyway, that's for vagus nerve stimulation. But all these nerves are probably related to each other, but we're not 100% sure about the physiology of these nerves. But if you look at the trigeminal nerve, there's also some interest. We know that transcranial direct current stimulation and transcranial direct alternating current stimulation got a lot of buzz, and it was quite successful for a whole list of indications. But actually, the last 2 years, there's a lot of controversy about direct current stimulation and alternating current stimulation, that it's probably not directly stimulating the brain. There was one paper published by Basaki that was saying that actually 75% of the current doesn't go to the brain and is just shunt away. But there's another paper done by a group in Leuven that actually suggests that transcranial direct current stimulation and transcranial alternating current stimulation is probably stimulating peripheral nerves rather than the brain itself. So it could be that a lot of the effects that we're seeing with TDCS and transcranial alternating current stimulation are actually still there, but that the explanation is not because we're directly modifying the brain, but through peripheral nerve stimulation, and in this case, trigeminal nerve stimulation. We had a different setup based on the vagus nerve ID, where we stimulate the tongue. The tongue has, the tongue ending has also a trigeminal nerve ending. And the idea is to do the same thing like for vagus nerve. We stimulate the tip of the tongue and at the same time pair it with auditory stimuli. So we had 3 groups, and in each group we had at least 100 people enrolled, and very similar to the design that we have for vagus nerve stimulation. They received the treatment for 12 weeks. At 6 weeks we have an interim analysis, and then we follow them up, and that was different than for the vagus nerve study, for 12 months after the treatment. Again, the primary outcome measure was the tinnitus handicap inventory, and that's measuring how severe the tinnitus is. And 7 points drop on the THI is actually clinical meaningful. What was the difference between the different arms? In arm 1, we basically paired auditory stimuli with tongue stimuli, and now we didn't care about the tinnitus tone. We just presented all possible auditory tones in comparison to what we did in the vagus nerve situation. In arm 2, we actually did the same thing as arm 1, with the exception that there's a small lag between the auditory stimulus and the tongue stimulus that we presented. And in arm 3, there's a huge delay between the auditory stimulus that we present and the tongue stimulus that we present. And in addition, we only present low frequency tones. Very similar to vagus nerve, what we saw is that actually independent of the group, we got a significant drop after 12 weeks of treatment. And that the drop was actually twice the minimal clinical important difference for tinnitus patients. But I think what was even more important was the long-term follow-up. So what we see is that very similar to vagus nerve stimulation is you have a fast-acting effect. After 6 weeks, you already have a huge effect, and then it stabilizes a little bit. So we continue with the treatment for another 6 weeks, but more or less you get the same effects. But then we follow them up for 12 months, and what you do see is that the people that were assigned to arm 1 actually have a better effect, a significant better effect than the people in arm 3, where you had a huge delay between the auditory stimulus and the tone stimulus, and the auditory stimuli were only low frequencies. The arm 2 that is actually closely related to arm 1 than arm 3 was floating somewhere in between. So it seems that the pairing is important, but only long term. Of course, for the vagus nerve study, we didn't follow them up for such a long time, so it could be that the effect was only generated after a longer time. So this is quite interesting. Does it mean that there was no mood component related? Well, there's actually a group in Brazil that is also trying to stimulate the trigeminal nerve. They do not stimulate tongue, but basically they stimulate the upper branch of the trigeminal nerve, the ophthalmic branch of the trigeminal nerve for depression, and they just stimulated it for 10 days in a row, and after 2 weeks they already see an effect between the sham group and the active group on depression. So there's definitely also a mood component related to it. It's not just pure the tinnitus tone, but it could also be that there's a mood component that is also modified. Anyway, so we have the vagus nerve, we have the trigeminal nerve that more or less show similar results. Another nerve that is less of interest to most researchers is the greater occipital nerve. It's the nerve on the back of your head that sends information, pain information and sensory information to your brain. There are people that are actually trying to stimulate that in an invasive way, and it's a very easy procedure to do. It's just a wire electrode that you inject. You can do it basically under local anesthesia. You do not have to do it a full-blown surgery. And it's shown to be effective for migraine and cluster headache. There's other groups that are doing the same approach, but they're stimulating the trigeminal nerve and basically stimulate the ophthalmic branch of the trigeminal nerve to get similar results. We also tried it, but now not just for migraine of cluster headache, but for people with bodily spread pain or fibromyalgia. So we implanted them, again, with a wire electrode in the neck, and you can see that there's a lot of change that you generate when you stimulate the greater occipital nerve. What was interesting is that we had very strong effects. If you look at the fibromyalgia impact questionnaire, the pain vigilance awareness questionnaire, and the numeric rating scale for pain. But of course, we wanted to see if we can also do it in a non-invasive way. So we used transcranial alternating current with the idea that we're stimulating actually peripheral nerves and not directly the brain, and we could generate the same effects as for the implanted approach. So this is quite interesting that with a non-invasive way, we could suppress pain in these people with chronic fibromyalgia. Another group in Michigan, led by Susan Shore, did the same thing, was stimulating the greater occipital nerve, but now was pairing it with auditory stimuli, similar to what we did for trigeminal nerve stimulation and for vagus nerve stimulation. And they showed in patients with tinnitus, and this was just a small study, that actually the people that were in the active group had a good response or a good suppression of their tinnitus percept, suggesting that, again, more, independent of the nerve that we're stimulating, that we are able to generate the same effects. But it's less known about the physiology of the greater occipital nerve and how it works. There is some preliminary evidence or anecdotal evidence that suggests that actually the greater occipital nerve is also connected to the nucleus tractus solitarius, and from there is activating these brain nuclei and basically induce the release of these neurochemicals. This is the only study I could find that shows that actually C2 has dense connections to the nucleus tractus solitarius, and that's the only thing that we know. So we try to do it in the scanner. We stimulated the greater occipital nerve and try to see what is happening in the locus ceruleus, the ventral tegmental area, the raphe nucleus, and the nucleus basalis. And we can see that in the active group, you see increased activity within these areas, suggesting that we're stimulating the similar pathway like for vagus nerve stimulation. What was really of interest to us is, can we also induce behavioral changes? And we know that the locus ceruleus is really important and a key area in developing new memories. There's a whole literature on that show that if you activate the nucleus tractus solitarius up to the locus ceruleus, that there's a direct connection with the hippocampus and the amygdala, and that it plays a key role in actually developing memories. And Clark already showed that in people with epilepsy, that vagus nerve stimulation can improve memory recognition. So our question was, well, can we also induce that by stimulating the greater occipital nerve? So we did a very easy task where students had to learn faces. We showed them 150 faces and also showed them a name. So this person, her name is Amber. This person's name is Douglas. And we asked them if it's a male or female. That was not really important for the task. It was just to be sure that they pay attention to the task. We waited for 15 minutes, and then we showed them basically the same images and also new images. And we just asked them, is this an old or a new face? And if it's an old face, what's the name of that person? What we did during what we call the encoding phase, when they were learning those faces, we stimulated the greater occipital nerve. These are the results. What was interesting is that the group that was in the active group in comparison to the sham group was actually able to remember more old faces than the sham group. For the new faces, we couldn't see an effect. But also we could see that the people that received occipital nerve stimulation during the encoding phase were able to recognize more names than the sham group. And this is a recognition task, so it's still easy because basically we give them cues to see if they remember that face or not. So we thought, let's make it a little bit more challenging. And keep in mind, these are done in college students. So we think, well, or at least I assume that they're already at the top of their game. So we looked at a different task. And there was a task developed by Roddicker that was published in Science that showed actually the way that we learn is, or the best approach to learn things is that we study, we test ourselves. We study, we test ourselves. And we do that over and over and over again, and that's the best way to learn. And he designed a specific task, and it's a word association task where people basically have to learn the English translation to Swahili words. And it's done in 4 blocks. And every time, basically, they get exposed to 75 words, and we show them the Swahili word and the English word. And then after they've done that, we test them. And we basically just show them the Swahili word and ask them what is the English translation of that Swahili word. But we made it a little bit more challenging. Roddicker showed that in one specific condition, that actually if you only test them for the words that they did not remember in the previous block, that it's actually a lot harder to remember. So for instance, in the first block, we showed them 75 words, and you're only able to remember 15 words in that first block. In the second block, we're only going to test you for 60 words. So those 15 words that you already remember, we're not going to test you on that. And people are actually have a hard time to remember those words long term. So we did this design, and every time during the study phase, we were stimulating the greater occipital nerve. We waited for 7 days, and then they came back, and we just tested them how many English translations of Swahili words did they remember. On the left side, you see basically the learning phase, so during day 1, and you can clearly see that independent of stimulating the greater occipital nerve or using a sham, they learn the same amount of words. But if they come back 7 days later, what we saw was that the people that received the stimulation actually were a lot better at remembering the English translation of Swahili words than the sham group. And it's about 15% better that they were doing. So this is quite impressive for a young group of college students. But we wanted to be sure that it's just stimulating the occipital nerve, that it's not just a sensation effect, and so on. So we tried to do the same effect in animals. We implanted animals targeting with a cuff electrode the occipital nerve. And we did 2 experiments. In one experiment, we basically did an object recognition task. So animals were exposed to objects and for half an hour. And then we looked how much time they spent basically looking or smelling those objects. And then immediately afterwards, we were stimulating the greater occipital nerve in one group, and in the other group, it was just the sham, so we were not stimulating the occipital nerve. We waited for 24 hours, and then we did the same task. And we just looked at how much time they spent smelling old objects versus new objects. And what we saw was that during the acquisition time, where they were learning the task, there was no difference. But 24 hours later, it was clear that they were spending a lot more time looking at the new objects or smelling at the new objects than the old objects, suggesting that they were able to remember those old objects, which fits with our human data. We did a second task where we did inhibitory avoidance. So animals like to stay in the dark. But every time that they would go in that dark space, they got a food shock. So we trained them, and then immediately after the task, we stimulated the occipital nerve for half an hour, and then again, we tested them 24 hours later. During the acquisition time, we see that both groups basically spent the same amount of time in that dark space, but during the retention time, 24 hours later, those animals that got occipital nerve stimulation tried to avoid that dark room for a longer time than the sham group. Again, suggesting that we can actually improve memory using occipital nerve stimulation. I'm almost done, I think. So at the same time that we were doing this task, we were also putting them in the scanner. And we were actually able to show that the active group, in comparison to the sham group, show more activity in the right hippocampus and the right amygdala during stimulation. And if we do a seed-based analysis, putting the seed in the locus ceruleus, what we see after stimulation is actually increased activity in the hippocampus, suggesting that there's increased connectivity or increased communication between the locus ceruleus and the hippocampus. We also did a Roy-to-Roy analysis where we looked at connectivity between the hippocampus and the amygdala and the hippocampus and the locus ceruleus, and the hippocampus and the locus ceruleus and the amygdala. And what we saw was during stimulation, you see increased connectivity for the active group in comparison to the sham group. And after stimulation, there was still increased connectivity between the locus ceruleus and the hippocampus. A final experiment was to be sure that there was release of norepinephrine. We only showed that there's activity changes in the locus ceruleus and hippocampus. So we looked at pupil dilations, and we looked at a specific biomarker, which is alpha amylase, which is a biomarker for the release of norepinephrine. So what we've done is we compare them before and after, and what we see is that for the active group, we see indeed increased pupil size, and we know that's related with norepinephrine activity. And in addition, during stimulation and after stimulation, what we also saw was increased alpha amylase release for the active group in comparison to the sham group. That is an indication for the release of norepinephrine. And we were also able to show that actually there's a correlation between pupil size and the release of norepinephrine measured by alpha amylase. Anyway, to go one step back, it seems like stimulating one of these peripheral nerves can generate more or less the same effect. And that depending how we stimulate, if we pair it with a task, that actually can help a lot of potential neurological disorders. And what I think has a lot of potential is when we stimulate those peripheral nerves, if we use specific parameters that we could potentially activate these specific brain nuclei in a very specific way. And I think that's one of the next steps that we want to do to see if using specific parameters, if we can activate one of these areas more than the other one and basically help specific neurological disorders. That's it. I thank you.
Thanks very much. The hypothesis is very heavily focused on activating neural systems that enhance paracortical and hippocampal attentional mechanisms. So this is really a heavy focus on attention. But what about the anterior cingulate cortex, and what about insula? Because really much of what could be reported is an awareness piece as much as is an attentional piece. So what about, I saw in the occipital nerve stimulation, it looked like activity in insula was reduced on that one panel, lower left-hand panel in one of your slides. Have you looked at, I guess the question is, have you looked at insula and have you looked at posterior anterior cingulate?
So we didn't look at the insula and the posterior cingulate. We looked at the dorsal-anterior cingulate cortex, which is actually correlated with the insula because it's part of the salience network. So it could be that there's also an attention component to it. If you basically look at pain, we know that the dorsal anterior cingulate cortex, together with insula, is part of your medial pain pathway. That seems to be really important in chronic pain, and that actually it's sometimes more important to change that network instead of just the somatosensory cortical activity.
Right. I mean, and Fada will talk about this, but you know, the practice of meditation frequently engages vagal tone. And so you wonder whether the mechanism that's being pursued is one that's also basically engaged through meditational practice. Have you thought about that?
Yes and no. I thought about it a little bit. I agree. I think you can definitely, with meditation, can basically activate these same networks. And I think, for instance, for pain, where we know that we activate that the attention network is important, but it's also possible that if you change the attention network, that you actually can draw your attention away from the pain.
Yes.
And that's very similar to what you can do with mindfulness. The pain is still there. And with tinnitus, it's the same thing, actually. A lot of people say, I have tinnitus, but I don't care about it because I do not pay attention to it. Other people are heavily focused on it, and potentially meditation or directly stimulating the anterior cingulate cortex. And we did a study where we basically targeted the anterior cingulate cortex. And the only thing that people were saying was actually, well, I can see it, I can still hear my tinnitus, but I don't care about it anymore because I'm paying attention to other things nowadays. So definitely there could be a link.
Really interesting. Other questions, please. Gert.
Very nice presentation. So the bottom line seems is that much of those stimulation strategies are directed towards the peripheral nervous system, right? And so that begs the question, so other modalities, right? So with the peripheral nervous system, you get into the midbrain before, I guess you can go through the rest of the nervous system. So then wouldn't other modalities like auditory stimulation perhaps be equally effective if it's correctly done in the right phase, say with your measured EEG signal or so?
Well, we know in tinnitus that it's not that effective. So if you do, for instance, auditory discrimination tasks, it's not very effective in tinnitus. So I think it's the pairing that is essential. That is more essential. So just doing auditory stimulation, they tried it over and over again. It doesn't seem to help that much. Even for cochlear implants, the effect that is generated is probably the masking of the tinnitus rather than actually removing the tinnitus, or even actually electrical stimulating the cochlea rather than actually eliminating the tinnitus. So it's just giving sensation to the cochlea. Those are the two assumptions. So.
Yes, I don't know anything about neuroscience. However, I have one question. In humans, sometimes it happens become vegetable existence. You mean there is no response. She or patient is alive, but it's no response at all. Sometimes music therapy works well. Is it maybe not the peripheral area of the brain, but can you explain something about how we can stimulate or something, especially the songs or music? If the patient is very familiar and very favorable music. Wake up. I heard of that and read about it. So.
Well, it's very hard to explain why some people respond and other people do not respond. We also see it for tinnitus. Some people respond, other people do not respond. For tinnitus, the strategy is basically we try with one therapy, then we go to the next one, the next one, the next one, until one works. Why some people respond to a certain treatment and others do not, we're in the dark about that. So we have no clear idea about that. So
You don't want to do such a...
I'm interested in doing that and doing that, but it's basically, for tinnitus research is the holy grail, basically, because that would make us able to predict, oh, you're this type of patient, this is the ideal treatment. And now basically we try 20 treatments at the same try 20 treatments, and then hopefully one will work. So.
Good. Yes. I'll bring the microphone to you.
So I'm a clinician, and I accidentally came across something that stopped tinnitus. So Rodolfo Linus published back in the late 90s the thalamocortical dysrhythmia theory. And he said it was for depression, tinnitus, chronic pain, and Parkinson's. So I work with Parkinson's, and there's that high and low frequency coupling that's going on. You break that up, and a lot of the symptoms of Parkinson's abate. One of my Parkinson's patients had tinnitus. And I broke up the low and high frequencies using neurofeedback, and within 3 sessions, it was gone. So it was quite remarkable how all those tinnitus, pain, Parkinson's are all linked with these frequencies.
Yes, the problem is with tinnitus that we think that there actually are different subtypes. And one could be explained through thalamocortical dysrhythmia that was introduced by Rodolfo Linus several years ago. But there's also an idea that for tinnitus in specific, there's also a top-down type of tinnitus that has nothing to do with hearing loss or whatever, and that there's basically a noise cancellation system that is not working that well. There's a whole literature about it by Joseph Roschecker that suggests that idea, actually. So, and it could be for those group of patients that actually the approach would not help. But for people that have, for instance, hearing loss, and because of that, because that's the idea, you have hearing loss, and because of that, there's changing, there's a reduction of alpha activity, there's increase in theta activity and gamma activity, that basically in the thalamus that is also projected to the auditory cortex, and that could be then an approach to basically with neurofeedback to reduce that gamma theta activity and increase alpha activity.
Sven, thank you very much for a great presentation.